As we all have experienced firsthand, life looks quite different today, and so does the world of cancer survivorship. It is my honor to introduce our next speaker, Dr. Kim Rhoads, who will share information about navigating this changing landscape of cancer survivorship and health disparities in the age of COVID-19. Dr. Rhoads is Associate Professor of Epidemiology and Biostatistics at the University of California, San Francisco School of Medicine. Although she no longer practices clinically, she is double board certified in general and colorectal surgery. Dr. Rhoads holds a master's degree in public health from the Harvard M.P.H. Chan School of Public Health, where she studied healthcare policy and management with an emphasis on minority health disparities and leadership. She is the founding director of the Stanford Cancer Institute's Community Partnership Program and currently serves as the Associate Director of Community Engagement at the UCSF Helen Diller Family Comprehensive Cancer Center. Dr. Rhoads earned her medical degree from the UCSF School of Medicine and her master's degree in health and medical sciences from UC Berkeley. It is my sincere pleasure to welcome Dr. Kim Rhoads.
Well, thank you so much for that introduction. And it is my pleasure to be here with you today to talk about navigating the landscape of cancer survivorship and health disparities in the age of COVID-19. So I'm going to go ahead and share my screen. So I just want to start by pointing out and acknowledging that COVID-19 is kind of ruining everything. Remember life before COVID-19? There were hugs, there were family visits, parties. There was even Thanksgiving, which can be fraught sometimes in these political times, but looking back now, it's something that we probably are all kind of missing. What is this novel coronavirus and how does it cause COVID-19? I'm going to talk a little bit about that. So the coronavirus is novel in part because although there are other coronaviruses in the family, this particular, like SARS and MERS, which you may have heard about several years back, this particular coronavirus has not really been seen to infect humans until now. The way it functions is it's a major cellular invader. The virus itself has what's called a spike protein. That's part of what gives its name coronavirus. That spike functions like a key, unlocking the door to a number of cells in our bodies. As long as that cell in your body has the right lock, the coronavirus has the key. It opens the door and lets itself in, and then injects its own genetic material into your cells. Once the genetic material from the virus is injected inside the cell, and that's shown in figure 3 here, the coronavirus actually turns your own cell into a machine, a coronavirus making machine, and it reproduces itself inside the cell. And then once it's formed a number of new particles, it then ruptures the cell. It ruptures your cell, which releases other virus particles out into the bloodstream and throughout your body to look for new cells to invade. So how does it actually spread? I think you probably know by now that, that the coronavirus is spread by droplets. And this is the moisture that's expelled during either coughing or sneezing. And these droplets carry viral particles. They can land on surfaces, and when other people touch those surfaces, they can pick them up on their hands. If the hands then are not washed or hand sanitizer applied, and the face is touched, anywhere around the mouth, the nose, and including the eyes, which is why you'll see so many people wearing face shields now, the virus can actually invade through that soft pink tissue that lines each of these areas. You can also get coronavirus by passing it from someone who's infected and has virus on their hands onto your hands. That's why we recommend the 6 feet of distance. We're really recommending against touching and shaking hands. Some of us are bumping elbows as a greeting instead of shaking hands. And again, this is just because of the potential for the passage of the disease. More recently, the World Health Organization and the Center for Disease Control have acknowledged the fact that not only is the virus spread in droplets, which are sort of the larger particles of moisture that sometimes you can see when someone sneezes or coughs, but actually that the virus can remain airborne. So what you can see in this picture is that the spread can be by aerosol. And the aerosol particles are not really visible to the naked eye. They're much, much smaller than the droplets. The droplets are heavy, so they fall to the surface. Because the aerosol is particles, smaller particles, it can float in the air for several hours. So if you walk through a cloud of this aerosolized particles, you can actually contract the virus in that way as well. And I want to recommend that if you have an opportunity to get these slides, which I'm happy to have shared with everyone, that you take a look at the link below, because this gives a very nice animated demonstration of how being in an enclosed space, being at small gatherings, not wearing masks, speaking, singing, or talking loudly can spread the virus, and provides you visual models of how many people approximately would be infected by being in any of these different types of settings. So how does it actually cause COVID-19? And I just want to make this distinction because I think it's important. The coronavirus is the infectious agent. COVID-19 is the disease that is caused by this infectious agent. So as I mentioned before, the virus can enter the cells through the mouth, the nose, or the eyes, the soft tissue around the eyes. And what happens is it migrates down into the lungs. And I'm going to really focus on pneumonia because that's one of the key impacts that the coronavirus has on the body that we see people suffer with COVID, and that can cause death. So what happens is as the cells, your cells are invaded by the viral particles, the infection itself makes its way down the windpipe into these small air passages in the lungs. Those small air passages typically have very thin walls. And so when you take a big deep breath, you breathe in oxygen, and that oxygen can pass through the thin walls of the air sac in the lung into the bloodstream to oxygenate the blood. Normally that layer, as I mentioned, between the blood vessel and the air sac is quite thin. So it's very easy for the oxygen to pass through. And please note that just a very small green double-headed arrow, which I'm trying to demonstrate the thickness of the wall in the air sac. So you can see that oxygen coming in can pass through easily. The blood gets oxygenated, and then through pumping of the heart gets delivered to the rest of the body, full of oxygen. With COVID, there's a virally mediated inflammation, and with inflammation comes fluid and cellular debris and a thickening of that wall of the small air sac. And what that means is it impairs oxygen's ability to pass through that wall. The blood doesn't get well oxygenated. People then feel short of breath. The organs in the body see blood passing through with no oxygen, and so they are also suffering and being damaged by what we call hypoxia, or a low level or a lack of oxygen. So we've been working at this for now 6 months, right? Following various guidelines that are recommended by the public health department. And, by now people are getting COVID fatigue, COVID prevention and mitigation fatigue. And so a big question is, are we there yet? So I want to talk a little bit about flattening the curve and why should we even bother to do such a thing. I think people got in the beginning of the warnings that were put out about coronavirus, got the wrong impression. There was an idea that flattening the curve was a destination, and that once we got there, everything was going to be fine and we could stop sort of following the public health guidelines. But the reality is that flattening the curve is really about preserving the resources that we have in our hospitals to provide care, not just for coronavirus, but for everything else. So in this little cartoon, what you can see is the dashed line represents the capacity of the healthcare system. The big hill that you see to the left in blue is the number of cases. And the idea here is that if the number of cases all occur at the same time at a high rate, that it will bypass the healthcare system's capacity to take care of folks. And you can think about this like, my mom asked me, why would a hospital run out of masks and gloves and personal protective equipment? And I told her, it's the same reason your grocery store ran out of toilet paper and chicken. And the reason is because if everybody's trying to get the same resource at the same time, then the system will be overwhelmed. The idea of flattening the curve is to keep the number of infections at any given time below the level at which the hospital could handle this capacity. And I want to really emphasize, this is not a destination. This is actually a holding pattern. Because the problem is when you have the scenario on the left, the hospital not only is overrun with its ability to take care of coronavirus and COVID cases, but it also is overrun in its capacity to take care of people who are having a heart attack or a stroke or even cancer. So the idea of flattening the curve is to take the precautions that are necessary to reduce the number of infections and the rate of transmission in order to get to some other development of either therapeutics or a vaccine. It's a holding pattern. Again, not a destination, not a finish line. It's not the end of COVID if we flatten the curve. So how are things going now? I'm sure you've been watching the news. We've all been watching the news. There's lots going on. There's not as much reporting on COVID right now for obvious reasons. But the reality is that the national trend is telling us that the rate of infection is on the rise. And this was predicted by our public health experts, that in the fall that we would see even more cases than we saw at the beginning of the year and through the summer. And indeed, they were correct. So the blue line, this graph from Kaiser Family Foundation is actually showing a number of different countries and their trend in COVID cases. But the blue line that is highlighted is showing the trend in the United States. And what you can see is that we're about to shoot into what is being referred to as our third wave. And you may have heard that yesterday, 120,000 cases in one day were diagnosed, surpassing yesterday's record of 100,000 cases in a day. So we are indeed, on a national basis, on the climb. So let's look at local trends. And here I've selected from the CDC's COVIDnet. I chose to look at hospitalizations and to share that with you. And the reason that I'm sharing hospitalizations, and it does say cases, but it's actually hospitalizations. And the reason I'm showing you hospitalizations is because there's a pattern. So first you get infections, then you get hospitalizations, and then you see a rise in mortality. And so I'm showing you sort of the average of all of the different metrics that we could be looking at to give you a sense of where California is relative to the rest of the country. And so what you can see is that in each of these lines on the left, which is showing the national trends, each of those lines represent an age group. The two flat lines at the bottom, which are sort of goldenrod and forest green on my side, you may not be able to see it in such detail, but they're quite flat and very low. Those are the age groups of 0 to 4 and 5 to 17-year-olds. So you can imagine and understand that that is not the group that is as grossly infected with COVID or suffering from COVID and being hospitalized for COVID as the older age groups. So the aqua line above that, the blue line, and then the orange line represent age groups 18 to 49, 50 to 64, and then 65 and beyond. And so obviously there's a pattern of higher rates of hospitalization as age increases. But if you look at the trends on the right, what you can see is that in California, our curve appears to be plateauing or flattening. And so you can see that there are obviously regional differences, and much of what's going on nationally is being driven in part by the Midwest. But California, despite the fact that things were looking a little bit grim in the past couple of months, is looking like it's leading an example of how we can control coronavirus. But I want to point out that it really matters locally what's going on. So even when you look at California by county, you can see a wide variation in the rate of cases as well as the rate of COVID deaths. And you may recall, if you're in Northern California, that we were one of the first parts of a state that led eventually to a full state to go into full shelter in place. The differences that you can see with the darker colors of cases in the left-hand panel in Central Valley and Southern California may be related to the fact that those areas did mandatory masking later than we did mandatory shelter in place later than Northern California. And so you can see the effects of following public health measures. You see similar effects in relation to COVID deaths. So what impact is COVID-19 having on cancer? And I'm going to start really by talking about what it's doing to our patterns of healthcare utilization as we've all been asked to shelter in place. So these data that I'm showing you right now show in pink breast cancer screening, in purple colon cancer screening, and in green cervical cancer screening. That is from data coming from across the country from hospitals that use the Epic electronic health record system. So they looked into all of the electronic health record systems from 2017 until January 2020, so prior to COVID. That rate of screening for each of these cancers is shown in the dashed black line in each panel. But what you can see is that the screening rate compared to that average over those 3 years is kind of jumping up and down around then until we get to 2020, and you see a significant drop off. So as compared to, for breast cancer screenings, an average of 10,000 weekly screens, what we were seeing after COVID hit was 559. So that's a nearly a 90% or more decrease in the rate of screening. You see a similar pattern for colorectal cancer as well as for cervical cancer. And now, what kind of implications is that going to have in the future? I'll talk about that in a second. But you can imagine this is dropping, quite close to zero when we're talking about national numbers of 560 people being screened for breast cancer. This graphic came out in April, so it was early April, May, so it was early in the pandemic. They have since produced another monograph in July, which shows that there has been an uptick in the rate of screening. However, it has not yet reached back to baseline. And as we all know, we were already under screening those who were eligible to screen to begin with. So it's just effectively another setback due to COVID. When we talk about diagnosis and treatment, we can look to appointment records and visits to get a sense of whether or not people are actually able to continue with their treatment or have had delays in their therapy while being diagnosed with cancer, or have even sought care as a new patient newly diagnosed with cancer. And what you can see again is around March, early March, there's an extreme drop off in the number of new patient visits. The rate of cancellations in some settings went as high as 80%. And follow-up visits were decreased about 25%. And that's all averaged together. And this data is reflecting community oncology practices, which is where about 80% of cancer care takes place. So Ned Sharpless, who is the director of the NIH, or excuse me, the National Cancer Institute at the NIH, put this graphic together to project early in the pandemic what they thought that the impact on excess mortality from colorectal and breast cancers would be, given the fact that I showed you that people were delaying screening or not being screened at all, even though they were age eligible or may even have had symptoms. And what you can see is a significant increase year over year for the next 10 years in the number of excess deaths. So these are not deaths that we might have anticipated based on people getting the therapy that they need, but these are excess deaths on the basis of people not getting the therapy that they need because of COVID. So it's a significant number, and these are not just individual. If you think about it for that year, what you'd have to add together is 5,000 excess breast cancer deaths and 4,000 excess colorectal cancer deaths. So that's nearly 10,000 additional deaths only in 2030. So all of these bars get added together to provide a number that is well over 20 to 30,000 additional deaths from breast and colorectal cancer due to COVID. So what about COVID-19 and cancer survival? So people who have cancer and the impact of getting COVID in that setting. There was a large study looking at COVID-19 outcomes in patients who are already diagnosed with cancer. And what they found was that about half of them had mild disease, but in the other half, they developed severe disease. And they tried to look at what the risk factors were. And I know there's a lot of numbers on this screen, but I want to draw your attention to two numbers in particular. One of the predictors of mortality with or severe COVID with cancer is age. And the other is the use of immune checkpoint inhibitors. And I think the most familiar one that people might be aware of is Keytruda, for example. And part of the complexity of COVID-19 is that what it is actually doing in your body is revving up your immune system. And with immune checkpoint inhibitors, they're also revving up your immune system to kill cancer cells. So the risk is slightly multiplied, despite the fact that people have this idea that if your immune system is weak, that you would do worse with COVID. The reality is, the more reactive your immune system is, the more inflammation you're going to get in response to COVID, and therefore the higher risk of organ damage due to poor oxygenation and the risk of pneumonia, as I talked about before. So when we looked at, that was the risk of getting severe COVID. There was another large cohort, a consortium that looked at patients from the United States, Spain, and other countries. And they actually looked at the risk of mortality in patients with cancer due to COVID. And surprisingly, and again, there's a lot of numbers on here, but I want to assure you that despite the fact that we do see disparities in cancer at baseline by race ethnicity, what they did not find in this large cohort was any increased risk of death due to race, ethnicity, or as related to COVID. However, the number of comorbidities, diabetes, lung disease, heart disease, high blood pressure, the number of comorbidities did predict a higher risk of death. So anywhere from 4 times increase the risk of death up to 11 or 12 times increase the risk, depending on the number of comorbid conditions. The other thing that they found was that the status of a person's cancer does have an impact. So as compared to someone who is in remission or has no evidence of disease, there was a 2-fold increase in the risk of death with active cancer in active treatment that is responsive to treatment, and even higher risk, up to 5-fold, if there is disease that is progressing or is not responsive to therapy. So cancer in and of itself, having cancer in and of itself, is a risk factor for mortality with COVID. So we try to reassure ourselves by asking, well, isn't the vaccine coming? Well, it's coming, but I just want to sort of set an expectation. You know, we have been in this period of some concept of Operation Warp Speed, suggesting that we're going to have a vaccine in the fastest time we've ever had a vaccine to a retrovirus. And I want to remind people, HIV is also retrovirus, and we still don't have a vaccine. So the idea of warp speed, I think, is a misplaced expectation. We held in our Office of Community Engagement, we held a forum for our community members to have a dialogue with one of the investigators who's running the AstraZeneca vaccine trial. And it was very informative because the questions really were coming directly from the community and are often questions that are not asked by academicians and clinicians, and really get at the heart of people's concerns about participating in clinical trials. At the time, AstraZeneca was on warp speed path. This was in early August, and we were being told that they were going to start recruitment and try to finish 35,000 enrollees in the trial by the end of August. Well, by the end of August, y'all probably recall that there was an adverse event in the AstraZeneca trial in the UK. Different trial than this trial, but nonetheless, it put the trial on hold. The trial continues to be on hold, is not yet back up and running. And subsequent to that, Johnson & Johnson vaccine also ran into a problem with an adverse event. Now, it's normal to have adverse events during large-scale clinical trials, and it's important that we are now on hold because that's the appropriate response rather than pedal to the metal, let's just go faster. So I want everybody to just really understand that we've really been in COVID for about 6 months. The typical time from trial for safety, which is a phase 1 trial, and efficacy, which is phase 2 trial, to the kind of clinical trial that we think of where people are randomized, you either get the vaccine or not, and then we wait for you to be exposed and see if the vaccine works. That timeline, if everything goes perfectly, is 18 months. We are at 6 months. So I just want everybody to really temper expectations about the idea of having a vaccine by the end of the year. So what we need to do instead is we need to start thinking about how do we adjust our lives to live with COVID-19, because it's going to be with us for a while. Our office is really trying to respond to what we see as the needs and requests in our community to hear about COVID and to understand more as we inside the institution understand more about COVID. So even though we have been focused and we traditionally focus on cancer education, dissemination of information, creating partnerships for cancer research, we have pivoted to COVID. And so if you go to our website at cancer.ucsf.edu and you search community, we will be the first bullet that comes up. And when you get to our website, I would recommend that you look in the archived Office of Community Engagement events. One of the talks that you'll find, and I want to just highlight a couple of highlights from it, and and this is interesting because it is COVID that is making it possible for us to have these archived events, taped and available for the community at large. But we had a talk from Dr. Hella Borno, who is one of our investigators, a medical oncologist specializing in prostate cancer and other genitourinary cancers, and clinical trials diversity, talk to us about the impacts of COVID and cancer and how she's dealing with that as a clinician and what people can expect or how they can start to think about tailoring their care in this era. One of the things that COVID is bringing us is the opportunity to promote and move forward with things that are kind of more patient-centered. So for example, we've had an explosion in telehealth visits. And what this graphic is showing you is the typical clinic visit is in blue. And this graph runs from December 30th through May. And what you can see is that the proportion of visits that are conducted in the clinic in person have shrunken dramatically. Video and phone visits are depicted in orange and yellow, and you can see over that same time period that they have significantly increased. And I think what it is pointed out and what Dr. Borno shared with us was that it really revealed that we don't always need the patients to come inside or into the clinic, because often we know that that is burdensome. I know our parking garage costs a whole lot of money. Just the stress of potentially traveling from far away to get to a specialized center, if that's where you're being treated, is another issue. And so there are ways to actually manage some things by not having the patient come into the hospital. I'm kind of cynical about healthcare, and I think that part of this, part of the reason we haven't done this previously is because it doesn't generate a lot of revenue for the hospital. It's more money for the hospital if you come into the facility. So again, I'm being cynical, but I'm also just pointing out that what COVID has kind of broken is the idea that everything has to be done in person and has to be done at the volume and frequency that we have traditionally done it in. So Dr. Borno provided this really handy framework. So again, I do hope that people get this slide deck and have an opportunity to use this as a guide to think about and try to think about when is it safe to have your visit from home or using telehealth versus going into the hospital, and to help people think through if your provider is holding you off and asking you not to come in, to put some kind of understanding or framework around why they might be doing that. So first, you need to think about the denominator. How much COVID-19 do you have in your local population? So there are a number of resources. Again, go back to some of the earlier slides that I showed where you can actually look into how COVID-19 is playing out in your county, in your local jurisdiction. And so if the disease burden is high, then as you walk through each of these other items, thinking about what's essential versus what is optional, thinking about the burden that you will carry as a patient or that the physician is placing on you as a patient, and anticipating future risk, those things will be colored by how much COVID is in your community at that time. If the disease burden is high, we don't want people moving around. That simply goes against all of the public health recommendations. The more people who are moving around, the higher chance of actually spreading the disease. So instead, we should focus only on essential activities, both in terms of care as well as in terms of grocery shopping versus going to the mall to spend the day out and about spending money. So same thing sort of applies in the healthcare setting. And then in terms of rethinking the burdens placed on the patient, think about and help your provider use this guide to think about, do I really need to come in for that? Is there a way for us to achieve whatever the goal is of that particular appointment, either using telehealth or even farming it out and partnering locally with your local provider to have you travel less, a shorter distance And then clinically thinking about whether or not the blood needs to be drawn, every single week, or can a week be skipped? And we have 2 weeks between visits, for example. In terms of anticipating future risks, this is not something that you can really do as a patient, but this is definitely something that your provider will be doing, is thinking about potential shortages and the impact of high burden of COVID on supply chains. So you probably have observed this in your grocery store, because sometimes the shelves are empty. Those are often supply chain issues related to COVID. If the disease burden is low, we can get back to something that's sort of closer to usual care. I'm not going to say normal, because we are going to be in for a new normal for some years to come. The other concept I want to introduce, because when I was putting this talk together, I thought, this is sort of bleak. And what I'm saying is we're going to have to live with COVID. And for some people, that means I'm going to have to be trapped in my house. It means increased rates of depression and anxiety, loneliness, isolation. And those things are also harmful, both to our mental health as well as our physical health. And in particular in cancer. And there is some research showing that isolation actually does predispose to the development of spontaneous tumors, and not in a short period of time, but over long periods of time. So it's not a good thing to be isolated all the time. So I wanted to share with you something that I think is potentially a new model for living with COVID and how we take care of each other. And that is called Umoja Health. And what that is a COVID-19 testing initiative that's been supported by UCSF, but it really is implemented by the community. Umoja means unity. It's the first night of Kwanzaa. It is really a reflection on the idea of the oneness and on how much we actually need each other. So what we do is we bring COVID-19 testing out to the community, and you can see all of these pictures here. Most of these folks are community members. I can count, if I look, I think I see myself in one picture. So I am the one UCSF employee in this picture. The rest of the folks are volunteer community providers, volunteer community members, faith leaders. And what they're doing is coming together to be out to bring COVID testing specifically to the African-American community for this project. But the reason that people come out, and this is something I've discovered over the several months that we've been doing this, the reason people come out is because they want to be around people. Now, the two people who have their arms around each other are married, so they live in the same bubble, and it's okay that they're touching. But we really try to observe the social distancing, the masking, the use of face shields. And what this ends up doing is actually educating the community members without pedantic about it. We are not being condescending to say that what's wrong with how things are going is that you are doing something wrong. And so you need to learn because you're uneducated. Instead, what we're doing is people are learning by participating. And so what happens is they carry this into their regular lives. And we can see that that is the case. I will just share with you that we've tested over 1,000 people, and we've only had 7 tests turn up positive. And we think that's because of this sort of iterative, you're learning as you're going along, and you're participating in uplifting the health of the community. So what we offer at our testing pop-ups is, COVID-19 testing to see if you're infected now, antibody testing to see if you've been infected in the past. And then we provide a giveaway bag with COVID information and resources. And then we also usually provide what we call a social services pavilion. And what we do there is we try to help people get signed up for healthcare. We get them signed up for CalFresh so they can get food. We've given away backpacks and books for kids to support education. And then we have a community wellness team, which I'll talk about in a second. But what we realized as we were moving along is that we could be offering other things because we are outdoors. It's safe. It's safer to be outdoors than indoors. We're all masked. We're observing COVID safety, but that will allow us to offer other things such as flu shots, which is going to help us get through and avoid a dual pandemic. And we've offered HIV testing. And we're now starting to put together materials to offer cancer control advice and resources to our participants. So effectively what we're doing is we're bringing the clinic out of the clinic, because the clinic, technically being an indoor space, is not the best space to be in during COVID, and we're bringing it outside to people. And I think people come because they want to be people, but the participants come because they feel invited by the community to be healthy. So I want to talk about the community wellness team real quick and then start to wrap up. So when I made this slide, we had 5 households that were positive. Now we've had 7. 2 of those households have accepted what we call community wellness team services. And what that is the community signs up to be either case managers or food and grocery deliverers and supply delivery service. And so people who test positive at our site get a phone call on a daily basis to check on their symptoms and see how they're doing. They get asked if they need any personal protective equipment or if they need cleaning supplies or groceries. Then whatever they need is actually delivered to them. I, as the clinical person on the back end, am monitoring the symptoms, and we're teaching our community members actually how to ask about symptoms, why they're asking about those symptoms, and we give them a script so they know how to assess. Does this sound like it's getting worse? Does this sound like it's getting better? And then we check in on a daily basis, and sometimes I have to make a determination that someone needs to go to the hospital. The reason I'm bringing this up right now is because it's very clear, and even from the presentation just before mine and talking about the importance of the support from the community and from the people around you to uplift your health, this community wellness team model is an opportunity for us to do the same thing in cancer. Who's going to shop for you when you're sick from chemo? Who's going to think about helping you get to radiation appointments on a daily basis? Who's going to sit with you during a chemotherapy infusion once that's allowed? Or FaceTime with you, or just be there to check on you in a way that communities can do, I think, and accomplish better than just the usual clinician or institutional person who has different goals than, yes, we want to get you well, but in terms of mental health support, compassion, and that other really human connection piece, that's where the community can really have a significant impact. So I wanted to share this model as a way to uplift the idea that, yes, we're going to be in COVID, but COVID is asking us to do things differently. So it is true that COVID is literally ruining everything. And in some ways, maybe that's a good thing. Our fearless leader of our community advisory board at UCSF, Arnold Perkins, who's the former director of the public health department in Alameda County, always says, if you want a different outcome, you have to be willing to try something you've never done before. And we think that Umoja Health and the idea of bringing health out into the community, having the community uplift the wellness of other community members, is that something new. And I want to just end by suggesting that, you know, our society is so focused on ourselves. And even in COVID, COVID is trying to show us that we actually need to work together. It's showing us that mask wearing is for other people. It's not necessarily for you. It does protect you, but it more protects other people from your droplets. And by replacing I with we can transform illness into wellness. Thank you.
Great. Thank you so much, Dr. Rhoads, for that incredibly informative discussion. You're doing some great work in the community. We're going to move on to a few questions. And I want to let our participants know that if your question is not answered live by Dr. Rhoads, she has very kindly agreed to answer questions offline, and we will post that on our website in the future. So be on the lookout for that. So first, a very quick question. Can any person be tested at the Umoja Community Clinic regardless of insurance status?
Yes, our goal is to provide no barrier testing. You've heard of low barrier testing. The high barrier testing is, do you have insurance? Do you have an ID? Do you have symptoms? Are you this? Are you that? At Umoja, you show up on site. You can register ahead of time, but you don't have to register. We'll get you registered while you're there. We don't turn anybody away. It's just part of what we're trying to do in terms of community wellness and unity.
Wonderful, thank you. Do you happen to know if being on endocrine therapy for breast cancer can increase the COVID risks?
So the therapy itself, we don't have studies to show us that the endocrine therapy itself increases the risk. The actual risk, the larger part of the risk is having a diagnosis of cancer. And so if you mean by that increase your risk of mortality, it's the cancer that is the problem. In terms of increasing your risk of getting COVID, the risk of getting COVID is being around people with COVID. So being exposed to the virus, and that risk is true for everyone, regardless of what other comorbidities that you have. So
Sure.
crowded living settings, congregate living settings, crowded homes, being an essential worker and having to go to work in a workplace where for example, the break room, there's no plexiglass or barriers between you and your colleagues as you're eating. The risk of getting COVID is being around somebody who has COVID.
Okay. And when a vaccine does become available, and if there are multiple to choose from, how would a cancer patient know which one might be best for them? And do you think that they'll be able to get the vaccine in the first phase of availability?
So I don't have confidence that that there will be multiple vaccines. I think one will probably emerge that works and is safe. In terms of getting access to it, it's going to depend on what kind of vaccine it is and how difficult it is to mass produce. What I would do if I were a person with a history of cancer or facing cancer and thinking about the vaccine, I would have a dialogue with my oncologist about the type of vaccine, because the different types of vaccines activate different parts of the immune system. And so that may be relevant to the types of therapeutic agents, the chemotherapy that people are on for cancer. I will point out that California, Washington State, and Oregon have joined together to make an assessment of whatever vaccine comes forward, that the three sets of state level leadership have agreed to come together and put their own independent panel together to assess safety before distributing the vaccine in those three states. So keep an eye out for the information that comes from that group.
Okay, thank you. We have multiple people asking for some clarification about how a cancer diagnosis can impact the risk of mortality from COVID. Is it just the diagnosis itself, or is it treatment? And for instance, if you have no evidence of disease at this point, are you still at higher risk? So maybe you could.
So from the COVID-19 and Cancer Consortium, the international consortium, they set as a baseline, meaning the lowest risk category, as having cancer in remission, fully treated, so no active, evidence of disease. But as you progressively go from no evidence of disease to, yes, I have cancer and it is responding to therapy, that risk of mortality is around, I believe it was 1.5 to 2 times the risk of someone who has no evidence of disease. And then for folks who are either not in treatment or the treatment is not working and their cancer is progressive, the risk of mortality is higher.
Got it, thank you. We have a few more questions about the Umoja model. Is it spread throughout California? When is the next event, or how would you find a center, and what type of COVID test is done there, and how long does it take to get results?
So Umoja Health is comes under the umbrella of unitedinhealth.org. You can go to the website there, and you can see what was done in San Francisco as well as what was done in Oakland. So Umoja is the Oakland version of United in Health. which is an initiative of the Sam Hawgood, the chancellor at UCSF, COVID health equity, public health equity initiative. We have just wrapped up our 8th pop-up. We do host a community meeting every Tuesday, although we skipped the last Tuesday because of the election. And so if you're interested, please feel free to email me or however Bay Area Cancer Connections would like you to connect with me. And we'd be happy to put you on the mailing list so you can hear about what we've done and what we're going to do next. We have just been invited to receive a large set of funding from Kaiser, who is going to be supporting additional work by Umoja. We haven't disseminated the concept across the state because we're just now writing up our successes, which is that we've attracted a number of first-time testers, and also really a highlight on the low rate of positivity and the trigger of trying to figure out why is that happening. We think it's because people are activated to follow the guidelines. So once that happens, I think we have more of an opportunity to spread the method, the approach of community partnership across the state. But for now, we're focused in the Bay Area. So San Francisco and Oakland are really the 2 cities where we are functioning. And we do the virology, or the test for the virus. We swab the nose. We do the swab in the front of the nose. We don't do the deep nasal swab. The test results come back in about 2 days, between 2 days and 3 days. And I think was that, and then we're doing antibody testing. I'm not sure if we're going to continue with antibody testing because it's unclear what the antibody test results mean. We don't know if that means you're immune or not.
Okay. Unfortunately, we've run out of time for questions. We do have quite a few more that did not get answered, so we will send those to you for a response. Thank you so much for agreeing to do that. And thank you so much for sharing your knowledge with us this morning. Thank you to the participants who came to listen. And we are going to move